Psychological predictors of sickle cell pain in pediatric and adult patients, a review of the literature. Lance is a member of the Sickle Cell Awareness Group of Ontario's Board of Directors and the chair of the SCD Patient Advisory and Advisory Council. He is a clinical psychology PhD candidate with a research and clinical interest in health psychology and trauma recovery. Some of his research projects include examining predictors of quality healthcare in children with blood disorders and factors associated with family resilience in families of children with lifelong illnesses. Lance is a part-time mental health counselor who is passionate about helping people discover new meaning to life. He aspires to design and appraise clinical interventions targeted at improving the quality of life of persons with chronic illnesses, including sickle cell disease and post-traumatic stress disorder. I'd now like to welcome our second speaker for today, Renée Bailey. And the title of her talk is going to be a quality improvement intervention for decreasing time to pain medication in sickle cell disease. Renée Bailey is a second-year medical student at the University of Toronto. She also holds a master's degree in global health. Renée deeply values supporting and advocating for the health and well-being of Black communities and other racial minorities. In addition to engaging in research to explore the impact of race-based barriers to access to timely pain management for patients with sickle cell disease, she also contributes to research exploring the impact of gun violence and COVID-19 in the Black community. Renée has also partnered with academic and mentorship programs such as Pathways to Education and Inner City Outreach to support Black youth. Renée also engages in spoken word art to translate Black communities' lived experiences with oppression and resilience. Welcome to both of you. Excited to hear you both speak. Lance will give you the floor, and then after I'll pop on, and then Renée, you can go, and then we'll have time for questions at the end. Okay, all right, thank you.
Thank you, Karen, and hello, everyone. I will be sharing on psychological predictors of sickle cell pain in children and adults, and this is based on a literature review. I would like to state that I have no conflict of interest to disclose. So we know that chronic pain is a major problem for people with sickle cell disease. Recurrent pain results in frequent and costly healthcare contacts, school or work absenteeism, emotional problems, and even poor quality of life. Consistent with other pediatric pain conditions, youth with sickle cell disease who experience more frequent pain tend to exhibit greater depressive symptoms, experience an interference in daily functioning, and even impairment across all domains. Psychological predictors, which are typically ways we go about describing how people think and feel about their pain, play a prominent role in the experiencing of sickle cell pain, including the maintenance and the exacerbation of chronic pain. Psychological predictors are also predictive of disability. So research suggests to us that there are biological, psychological, and social predictors of sickle cell pain. However, much less is known about the psychological factors that really predict sickle cell pain. And so this prompted me to ask the question, what psychological factors predict sickle cell pain in pediatric and adult population? One study revealed that coping and mood are associated with pain frequency. Sherlens and colleagues decided to explore the biopsychosocial factors associated with pediatric sickle cell disease pain. So they sampled 76 children between 8 and 19 years and have these participants complete measures of coping, mood, family functioning, and even reported on their pain features, including the pain history, pain frequency, pain duration, and pain intensity. The authors used a coping strategy questionnaire for sickle cell pain, which is an 80-item questionnaire that assesses coping behaviors that children have to deal with pain. They relied on the coping attempts and the negative thinking subscales So these were the outcomes. They wanted to know about coping attempts and negative thinking. Coping attempts had to do with adaptive coping responses, such as cognitive behavioral strategies. For example, I think of things I enjoy doing. In terms of negative thinking measures, that was more specific to maladaptive coping responses, such as catastrophic thinking, which has to do with the thought that it is terrible and it is never going to get better. In terms of mood as an outcome, they used the positive and negative affect scale, and they asked the children to rate the extent to which they felt different positive and negative emotions in the past week. So the authors found that child negative thinking and coping were significant predictors of sickle cell pain. What this basically means is that the more negative thinking the child reported, or the sample reported, the more frequent pain episodes they tended to experience. Positive mood, however, was negatively associated with pain frequency, pain duration, and even healthcare utilization. So the more positive mood reported, the less pain episodes, and even the shorter duration of pain. Of course, the study came with limitations. They really had a small sample size. We know that developmental factors tend to influence the ways children cope with pain in general. Males were underrepresented, and the study relied on retrospective reports of acute pain, which may be flawed, and they did not look at chronic pain. Nevertheless, their findings did suggest that there is an association between negative mood and negative thinking in particular with sickle cell pain. The second study looked at 41 adults with sickle cell disease, and they were required to complete daily mood and stress diaries after being prompted by a programmable wristwatch. The aim of this study was to look at the association between daily mood and stress as it relates to pain. So they had the participants were asked to say on the day whether they were having pain. They responded to the question, are you having any sickle cell pain today? And they were asked to record pain duration and even ER visit decisions. The researchers found that higher levels of positive mood significantly was associated with lower ratings of sickle cell pain on same day and even 2 days later. Higher levels of negative mood significantly associated with higher ratings of same-day pain and even pain up to 2 days later. They also found that higher stress levels significantly were associated with higher levels of same-day pain and pain 2 days later. We know that using diary in forms of research can be flawed due to missing data and variability in the number of days. In particular, only a small number of participants completed 3 to 4 weeks of mostly consecutive diaries, even though they did have a programmable wristwatch that prompted them to write in these diaries. This was not a random sampling technique, and so that might have contributed to bias within the findings as well. The third study looked at pain catastrophizing and chronic pain self-efficacy being associated with pain intensity and pain disability. Now, chronic pain self-efficacy has to do with how you see yourself handling pain. It's the confidence in your ability to get through pain. And pain catastrophizing has to do with thinking really catastrophic thoughts or extreme thoughts about the pain. What they did was they sampled adults from a single institution, and they had them complete measures related to pain catastrophizing and even chronic pain and self-efficacy. They found that pain catastrophizing and chronic pain self-efficacy were the most significantly related to chronic pain. Chronic pain intensity and disability were associated with higher pain catastrophizing and lower self-efficacy. Pain catastrophizing and chronic pain intensity and disability are related, and the authors found that negative relationship existed between chronic pain self-efficacy and the pain intensity. So overall, the more people tended to catastrophize about their pain, thinking worst possible outcomes, the higher pain they were experiencing. If they are thinking that they have the ability to manage this pain well, they were more likely to experience a greater intensity of pain and even experience chronic pain disability. So this too had limitations. They relied on self-report measures. They took the sample from just one single institution, so it's not generalizable to other sickle cell disease population, and they had mostly females. So having discovered what the literature has to say about the psychological factors, this motivated me to look at ways of coping with these psychological factors. And my research revealed that there are three main strategies or coping mechanisms that can be used to address sickle cell pain: cognitive behavioral therapy, mindfulness-based interventions, religiosity, and spirituality were found to be highly feasible in addressing sickle cell disease pain. I argue that future research should look at positive mood in people with sickle cell disease. More studies on positive mood will give us an idea as to how to promote positive psychological well-being and to optimize adjustment to sickle cell pain. I believe that research should look at the mechanisms that contribute to gender-based coping. Is it possible that males tend to cope differently with pain than females, and which would be the most effective coping strategies for men versus women? Studies should also explore different self-management resources for coping suitably within the pediatric and the adult populations, and utilize technology in delivering non-pharmacological interventions to address sickle cell pain. As we are talking about health equity, I suggest that healthcare providers consider the multiple predictors of pain, including the psychological predictors, and begin to target them. I'm also suggesting that healthcare providers adhere to the interprofessional or the multidisciplinary team approach to treating sickle cell pain. Psychologists, social workers, OTs, and everyone who works with sickle cell patients should be mindful of evidence-based treatment approaches that target negative thinking, pain catastrophizing, and chronic pain, low self-efficacy. And also work with patients to gain awareness around incorporating practical, non-pharmacological strategies in their self-management of their sickle cell pain. So overall, it's discovered that predictors of sickle cell pain are more than just biological and social factors. There are negative thinking, pain catastrophizing, and chronic pain self-efficacy. Increased daily stress and negative mood may lead to pain onset and even make it more difficult to manage pain up to 2 days later or even longer. However, an optimistic or positive mood may serve to buffer against negative consequences of sickle cell pain. Given the unpredictable nature of sickle cell pain, identifying psychological precipitants of pain can be helpful to better support the management of sickle cell pain, and non-pharmacological interventions such as CBT, mindfulness, spirituality, and religiosity can address these psychological associates of sickle cell pain and reduce pain. That's it for my presentation.
Awesome. I was overwriting notes, so it was great. Thank you so much for sharing that. I look forward to the question period after.
It's almost hard to hear you, Karen.
Oh.
Ah.
It's the little things. Putting my headset on definitely helps. Thank you for telling me that. Thank you so much. As I'm still jotting notes. Yeah, I took my headset. Oh, no. You guys are still having fun.
Okay, how are we now? Yeah,
Perfect.
sure. Okay, great. I unplugged my headphones just to listen out loud and just relax. And I got really relaxed. It was great because I just enjoy hearing the different parts, just learning the whole spectrum, right? And then being able to hone in so closely on the impact, the psychological predictors, something I really haven't been able to explore. So thank you for opening that up. We will invite Renée to join us and you can get started. Thank you.
Thank you so much. Okay, let me share my screen. All right, and wonderful job, Lance, with your presentation. Okay, let me, not as tech savvy here. Okay. I think I'm almost ready to go. All right. Hello, everyone. Thank you, Ms. Karen, for the introduction. My name, again, is Renée. I'm a second-year medical student at the University of Toronto, and it is such a privilege and honor to be speaking at the second annual Ontario Sickle Cell Summit on behalf of my research team, led by Dr. Jennifer Bryan at UHN. So I will just take a moment to acknowledge a few people whose slides I modified for the presentation. So thank you, Dr. Jennifer Bryan, Dr. Marcus Gouliat, Nurse Ruth Apia Boateng, and patient advocate Serena Thompson for the slides. Today, I'm going to be sharing some developments, current developments of a research project we're working on entitled A Quality Improvement Intervention for Decreasing Time to Pain Medication in Sickle Cell Disease. I'd like to just take a quick moment to acknowledge the financial support that we've received for the study from the Physician Council on Quality and Safety and the UHN STAR EM program. Okay. So I'd also like to just take a moment to acknowledge the team at UHN. So just to provide some context, UHN is a multi-site hospital in Toronto, and it is home to one of the largest red blood cell disorder clinics in North America. And all the people, wonderful people you see listed here are a part of our team called the UHN Emergency Department Sickle Cell Working Group. Our group began in 2020 with the purpose and intention of exploring and addressing barriers to care for patients with sickle cell disease. So I'm honored to be a part of that team. And we really are multidisciplinary. This team is composed of patients with sickle cell disease, community advocates, learners, emergency physicians, nurses, and allied healthcare workers. So we truly are a team built on collaboration. In terms of the background for this research study, it's long been known through past research and through patient experience that people living with sickle cell disease face significant barriers to emergency department care due to a variety of factors such as stigma, anti-Black racism, a lack of healthcare provider education on some of the complications and presentations of this disease, and the fear surrounding our opioid epidemic that we're facing. And so many patients living with sickle cell disease feel as though their concerns are not heard, addressed, or understood adequately. Many patients have reported being left for extended periods of time without pain medication, feeling that their pain experiences weren't believed by emergency department doctors and nurses and not taken seriously. And a part of this reason is because the source of pain for sickle cell disease isn't visible as it would be for someone who comes in for a broken arm, for instance. But another large reason for why this reality exists is because sickle cell disease historically has been labeled as a Black disease. And this has functioned to link this condition to race and ultimately to a lot of the negative cultural themes and prejudices that we know surround race in our society. So delay in pain management, particularly when it comes to emergency department visits for patients, is a significant barrier to care that needs to be addressed. And so for this research study, what we chose to do is focus on the time that it takes, or examine the time that it takes for patients to receive pain management or pain medication, in hopes of being able to use this data to improve patient satisfaction and patient care and start to take those meaningful steps toward practical anti-racism in emergency medicine. So where did we start? What did we look to first? Well, we started off by referring to the Ontario Clinical Handbook for Sickle Cell Disease, Vaso-Occlusive Crisis, which offer guidelines around the management of acute pain crises that are experienced by patients with sickle cell disease. And this handbook recommends that patients with sickle cell disease should wait no longer than 30 minutes after being triaged and emerge before receiving pain medication. This is a standard that's also emphasized in the Ontario Health Quality Standards, and I know that this was talked about earlier on in the plenary session this morning. So what we did is an initial data analysis to see where we're at in terms of reaching this provincially designed pain medication target. And unfortunately, we found that we're not reaching that as much as we should be. So we performed a review of patient visits to emergency departments at Toronto General Hospital and Toronto Western Hospital by patients with sickle cell disease between January 2019 to January 2020. And these UHN emergency departments receive around 250 visits for sickle cell disease complications every year. And as we can see, based on the graphs on the slide, we're reaching, based on that data, the provincially recommended time to pain medication in only 5.6% of visits, with the median time to opioid analgesia being around 87 minutes. So after gathering this data, we really wanted to see what we can do differently. How can we improve this time to pain medication, given how debilitating these pain crises can be? So between November 2020 to September 2021, we applied 3 main interventions to improve time to pain management. So in order to see whether or not those interventions really were successful, whether they made a difference to decreasing that time to pain medication, what we did is we analyzed visits post-intervention to visits before the interventions were implemented, so the baseline data that I just showed you, to see if there was any improvement. And I'll talk a little bit about some of the preliminary data findings from the post-intervention data, but I do want to just take a quick moment to highlight those 3 main interventions that we implemented. So the first intervention included large community town halls or community symposiums to increase community engagement. And this started in November of 2020. And we focused, I love this slide, it's so colorful, but we focused on topics such as disparity in healthcare, alternative treatment, and standards of care, all discussed within the context of sickle cell disease. And because these symposiums were virtual and they were free, it really helped us overcome some of the barriers that would have implicated community or impeded on community engagement, such as cost, for instance. Sorry about that. The next thing that we did is we revised order sets used in the emergency departments at Toronto General and Toronto Western Hospital between January 2021 to September 2021. And just to give a little bit of a context here, order sets really are a standard set of assessment or management steps that physicians can use to guide care for certain conditions. So there's a bit of a screenshot of the sickle cell order set on the slide. And within the context of sickle cell disease, using order sets in patient encounters can improve time to analgesia by 66 minutes compared to encounters where order sets were not used. So some of the changes that we made to the order set includes, 1, explicitly setting a 30-minute minute target for starting pain medication on these order sets. Another thing that we included or revised is implementing non-pharmacological methods of pain control onto these order sets. So, seeing if, the patient requires oxygen, if the patient needs a warm blanket, making sure that, they have access to electronic devices or food and drink to, make their experience a little bit more comforting. If possible, seeing if a support person can be with them at bedside. Another thing that we revised in the order set is including a list of criteria for discharge from the emergency department. So this included, some of the criteria included, 1, seeing if the patient is ready to be discharged, seeing if they're tolerating on oral fluids, if they're managing well on oral analgesics, and making sure that there are no acute medical issues that haven't been addressed before being discharged. So really modifying this order set, I have to say, was such an integrated effort from a variety of stakeholders. This was the first time at UHN where we had patient advocates being involved in fixing the order set. This was also the first time where we had non-pharmacological methods of pain control being included on an order set. So I'm very proud for, the changes, the positive changes that we've made. Now, for the third intervention, we implemented hybrid patient-led healthcare provider education sessions that took place between December 2020 to February 2021. So usually in the mornings in the emergency departments at Toronto General and Toronto Western Hospital, nurses, doctors, and anybody working in that department meets together to talk about important issues in the emerge, such as new patient resources, patient updates, safety concerns. So these information sessions took place at those times in order for us to try to reach as many doctors and nurses and learners as possible. And this was an incredible educational opportunity for new nurses, especially who were onboarding at UHN, for them to learn about sickle cell disease and learn about how we can manage and care for people dealing with this condition in an equitable way. So after all these interventions were implemented, did things change? Did we see any form of improvement? Well, we did perform a preliminary data analysis of visits during and post-intervention, mainly between January 2021 to January 2022. So we're going to continue with an in-depth analysis later on this year, but I will share some of the preliminary findings that we've discovered. So one of the things that we found is that visits post-intervention had 2.2 times higher odds of receiving opioid pain analgesia in less than 30 minutes, so within that provincially recommended timeline compared to the pre-period. And this information we found is statistically significant. So here are two graphs showing the percentage of visits that were analyzed, and we analyzed a total of 270 emergency department visits that received opioid analgesia within that 30-minute time period. So we can see based on the pie chart that there were 16.9% of those visits where opioid analgesia was given in 30 minutes or less. And this is compared to the 5.6% that we saw in the baseline data that I showed you earlier. So that is promising findings. Another thing that we found was that the time from triage to opioid analgesia in terms of minutes was insignificant with the preliminary data. And so this lack of statistical significance means that the difference that we did see could be due to chance. And that might reflect some larger healthcare system changes that occurred pre and during pandemic. And there are quite a few. But some of those larger healthcare system changes can include patient fears that increase people's reluctance to go to the emergency department during this time because of the pervasive spread of the COVID-19 virus. It can also include the changing availability of primary and preventative care, especially during the peak of COVID-19. We did see a rapid transition to virtual care in a lot of these settings. It can also include changes to school and the work environment, as well as changes in the prevalence of certain seasonal respiratory viruses that decreased during the time of COVID-19. And again, understanding their direct impact on our data is hard to appreciate at this moment, but it is something to consider. So in terms of next steps, how we're going to move forward with our research and our data analysis, our upcoming plan is to use a control group, and more specifically patients with renal colic, for comparison. So these patients also experience extreme pain, but they didn't receive any targeted education intervention in the same way that we saw with our sickle cell disease data group. So we would expect to see that any large healthcare system changes that might have impacted our data would also affect patients with renal colic similarly as they did with our patients with sickle cell disease. So even after that comparison, if we still find an additional difference in the pre-post intervention data for our sickle cell disease group, we would likely attribute that positive change to the interventions that we put in place. So there's more to come. I'm excited to see what's next. But I think, myself and the group realize how important continuing this work is for, building a foundation of research knowledge to push policy efforts around sickle cell disease care in the future. We realize that the work that we're doing is working to create a foundation of race-based data in Canada, which we know is currently lacking at this time. And we also know that this research is serving as a model for how we can co-design research and quality improvement initiatives with patient and community input. And we've seen how this is played out in our research, and it's just a wonderful thing to be able to observe the way that we're establishing such meaningful relationships between hospitals and organizations such as SCAGO and SCAO. So we're looking forward to the rest of this work. And I thank you so much for having this opportunity to speak today. And I look forward to taking any questions that you have. So thank you.
That was great. Thank you so much, Renée. What I found interesting, I've been looking at the chart, trying to see where was that change. I really appreciate seeing that jump from 5% up to 16%. I really enjoyed, I'm just going to say a couple of things and then other people can certainly share. But I really enjoyed the patient-led healthcare provider education sessions. And a question I have, and Lance, you're welcome to join us because we're going to open up the floor for questions. It looked like it was a nurse. And I heard you say hybrid, so I just wanted to understand that better. Was it a nurse doing, had a computer, there was a patient on the screen telling their story? Or was it that the nurse, could you talk a bit more, like what did that look like?
Sure. So I believe in the picture, and Dr. Jennifer Bryan, if she was here, could correct me, was Serena, who is a patient advocate. So I believe that both of them were leading that session with Ruth being in person, Serena being online, among doctors, nurses, and other healthcare professionals that were there.
Oh, so awesome. Thank you. I just wanted to clarify that because I wanted to, I wanted to appreciate the healthcare provider piece, and then how did the patient play a piece? So the co-creation of the presentation and then actually the delivery of it as well. That's so cool. I love it. I loved a lot of the things you mentioned. Lots of forward thinking. So let me just jump in the Q&A and let me open my participant now here so I can make sure I'm not missing anybody. Okay, so we do have a question here. Hello, did you find any changes in time of opioid administration in younger cohorts, 15 to 20 years old, or even kids? But I know maybe lots of the pediatric SCD patients may be directed to sick kids.
Yes, I believe so. That's a wonderful question, Claire, and thank you for asking that. So I've been involved in assessing some of the chart reviews, and from my understanding, we've looked at adults. So we've assessed patient visits or visits by patients who are 18 years or older. And right now we haven't analyzed the data based on age cohorts. We're just looking at all the visits all together, but that's something to consider as well, the younger age group.
Thank you. I totally agree with that. It's always hard to do like an entire, like everybody at once, because it's important for everyone. So it's good to know there is some action that is happening, and then hopefully it can translate, whether it translates to pediatrics or to other adult centers, that sharing of info is really key too, right? Like, so hopefully conferences like this get people connected who may want to do something very similar. So Lance, when I was listening to your presentation, what I found really interesting was around the self-efficacy piece. So decreased chronic pain self-efficacy, and that increased pain, increased pain, I have intensity, and then I also have something else though, Oh, catastrophizing. There we go. Yes.
Yeah.
Right. So decreased self-efficacy tended to be associated with higher levels of pain catastrophizing, and that can seem to then be linked to higher pain intensities being reported by patients. Do I have that right, first of all, before I...
Actually,
yeah, tell me.
Yeah. So pain catastrophizing is one aspect. So high pain catastrophizing will or is associated with pain intensity, high pain intensity. Chronic pain self-efficacy is another aspect. And high or low pain self-efficacy, let me say that again. Low chronic pain self-efficacy will or is associated with higher levels of pain intensity and even disability.
And so, like, as first steps as healthcare providers, like, what are some of those things? Like, when we're in clinics, are there certain questions that we should be starting out with asking? Like, how do we start to break that barrier down where we're not actually really exploring that piece? Do you have some suggestions, like, around what we might want to consider as healthcare providers?
Yeah, in terms of the self-efficacy, we really want patients to be confident in their ability to utilize different self-management strategies. So we talk much about deep breathing. We talk much about being able to know when to take your pain medications rather than delaying it. So all of that will come under their confidence being built to manage their pain. So what a healthcare provider can do is facilitate a discussion on that. How are you managing your pain? What have you found to be most helpful for you? Just so that they can be at that place where they are thinking about what they can do, because it's really about their input as well and their ability to manage your pain.
Thank you. Go.
I just wanted to say something about pain catastrophizing. It's really something that may require the support of social workers and even counselors just to chip away at. We know that it's easy to think worst case scenario when you're experiencing a pain crisis. So just helping to bring about perspective in terms of, it's not the end of the world, and just doing what is necessary to get through it can also address pain catastrophizing.
And I think when you say when you say that, it reminds me of when Serena had mentioned in her session around hiding the pain based a bit on, and she named it embarrassment, the embarrassment of how severe the pain is. And really, I kind of feel like associated with the situation in which you're in and not being able really to get the care in which you need. And so that whole pain catastrophizing, the addition of social work and psychology or support or counselor, counselor support. I think psychology probably has a spot too, but right, like, how do we, like, services, we just tend to pocket them first, nursing, doctor, okay, then, let's add on social work. But really, it seems that you really need that comprehensive team on every level, right, to address what seems to be quite an extensive disease. It impacts everything almost, what we're hearing.
I agree.
Thank you. We do have a question. Got a couple. Let me just ask. Okay, so this question is, I think it's for Lance. I really love that you brought so much light to the psychological well-being aspects of sickle cell disease, Lance. Great job, guys. We have another great job in advocating for using the 3 Ps in management of pain in the eMERGE. So the 3 Ps of it, can we clear, what are the 3 Ps? Like, maybe for those that are in the audience, someone may not know, what are the 3 Ps in pain management? Do you want to chat about that, Renee, a little bit?
I was going to actually ask that person to clarify myself.
I love it. Okay. So we're talking about physical. I love that you're doing, they can unmute themselves if they'd like, or I could tackle it. It is an anonymous attendee. So it's fair that I don't mind addressing it. So I'll take a stab at it and we'll see. Hopefully I got it right. Okay. So physical, right? So we talked about physical pain and, the dose of opioid you would use. We've got psychological. So we've just talked about the impact, the psychological predictors. Lance talked a bit about that earlier on. Someone can type it in the chat: physical, psychological, and I go into non-pharmacological, but oh man, the third piece is escaping me. Let me see if someone's going to help me out. Yes, the 3 Ps of pain management. I agree, Dr. Kirby, but Dr. Kirby, help me out a little bit more. What's the third P here? So I'm going to move on to the next question. And before we're done, you are going to know what the 3 Ps of pain management are, because I'm like, okay, it is. I'm just going to pull it up because I just think it's so important to answer it.
Well, and I can just add to that really quickly.
Please.
So in addition to some of the variables that I mentioned, time to opioid analgesia, whether or not patients are receiving opioid analgesia within that 30-minute time period, we're also going to be assessing some of those patient visits by looking at their charts. We're going to look at a few more variables, and one of the variables that we're going to also assess include the pain score. So another thing that we included in the opioid or the order set is making sure that nurses are trying to record as many pain scores when they interact with patients as possible. So that's another thing that we're going to be looking at when we finalize the chart review. So I just thought I'd share that as well.
Thank you. And in that time, I've still not found the answer, but that's okay. We're going to come back to that.
Dr. Kirby,
did someone type it? Oh,
pharmacological, physical, and psychological. Thank
you.
Oh,
thank you. I think I put pharmacological and physical together. Thank you so much. And there are a number of, actually, let me move on to questions, because there's a number of questions that popped up and I would hate for us not to get to them, for us to ensure we can try to cover everything. Okay, so another question: what sort of resources and data did you need to evaluate the time to medication? Looks like a great model to implement in other centers with high numbers of sickle cell patients. Did you also look at the triage levels of patients that present?
Yeah, so that we did look at as well. That data was provided by decision support at UHN. So it wasn't something that we had to look back at the chart reviews to review. The main thing that we did refer to when it comes to that, the time to opioid analgesia, was the clinical handbook, which suggests that we should be providing patients with sickle cell disease pain medication within that 30-minute time period. But another, and I forgot the title of the research article, but there was a research study that was done in the US that followed a very similar format in terms of seeing, how long patients have to wait who have sickle cell disease when they go into the emergency department to receive opioid analgesia. And they also did that comparison with patients with renal colic to see what discrepancies lie between those two groups. So that's another main article that we're referring to. But I hope I answered your question properly.
I feel like yes, and we'll see if Sanjeev has anything further to say. I loved it. All of the things that popped up in the Q&A were those helping me, right, to get up to get the 3 Ps. Right,
it's a learning opportunity for all of us.
Right, I love it. Right. So let's see. Marcy's got her hand up. Let me just allow you here to unmute yourself, and you can go ahead and ask your question. Marcia, you're welcome to, I let you just have to click that you're able to unmute.
Sorry, I was trying to answer the 3 Ps because I was the one who put the question in.
Thanks, Marcia.
Yeah, I'm not anonymous. I was the one who put it in. I just wanted to see who knew the 3 Ps. Yes.
Well, I definitely did not pass, but
okay.
Thank you, Marcia. It's just great, right? The community comes to and supports each other, and it's just so wonderful. I'm looking at the time, guys. We are at exactly 2:25. So this session is coming to an end. Thank you all so much. We ask you please to join us for the closing remarks. So I will end this webinar and you can just jump into the closing remarks. Thank you all for coming today.
Thank you so much, everyone. Have a wonderful day.
Thank you, speakers.
Take care all. Bye.